So hanging out at Casey Endurance with Nathan Carlson, Joel Satgast, Casey running mate, PT and performance in Nathan Carlson. So we're joined today by Brooklyn. What's your last name?
Swantek.
Salantak or Swantak?
Swantek.
Swantek, okay. I hate bastardizing pronunciation of people's names. So what we're going to do is take Brooklyn. You're actually a second year PT student, correct?
Mm-hmm. Yep.
Awesome. Congratulations. Not that you finished yet, but you're going down that path. I think it's a great career. So we're going to just take you through a simple postural scan. And we work in the capacity as physical therapists, and we also do a lot of performance coaching. So there's a continuum in terms of the clients that we see. So we take all of our, whether they're patients or clients, meaning it's more for performance or wellness, through just a general screen and some basic orthopedic examination. So I'm going to step back here, and we're just going to do a simple postural assessment and screen. And again, we know that with runners in particular, that static postural alignment doesn't really mean so much in terms of risk factors or people who may be at a predisposition to injuries. With that said, we're going to take a look at the person in front of us and just see if we pick up anything that we need to plug into the clinical reasoning process or that may influence our decisions or dictate sort of barking up one particular tree. So I'm going to take a step back and just hang out, whatever feels comfortable as we stare at you. All right. So with Brooklyn, the only thing that really jumps out at first glance is she has a little bit of knee varus and maybe a little bit of like femoral internal rotation. And these are not things that I would even be bringing to her attention because they're things. This is her structure right now. So we need to ultimately take her through different movements and assessments and really find out what her goals are and what her meaningful tasks are and the demands that she places on herself between sport as well as life. So nothing really jumps out at me. Do you guys see anything? Great. So from here, what we're going to do is just take you through some simple tests and assessments. So can you go ahead and lift up your great toe in isolation? So this is something we take a lot of runners through just to get a window into their toe dexterity as well as how coordinated they are. This is also something that we'll get a window, and you can see as she's just starting to practice this a little bit, that she's starting to become a little bit more proficient. But this also ties into a lower quarter screen. So we know with great toe extension, we're looking at the L5 myotome. All right. And how about the lesser toes? Are you able to point the great toe into the ground and lift up the lesser toes? Looks like you're a little bit better with that. So we're getting a window into the flexor hallucis brevis, which is the only intrinsic foot muscle that's going to provide support for the medial longitudinal arch. Let's have you just pick a side to balance on and just go ahead and hold that. Again, we're looking at her willingness to load and just to see what her preferred side is in terms of initiating loading. Go ahead and come back down. You'll see a little bit of toe gripping when she goes into that. So go ahead back into single leg balance on the right. Okay, and don't get too hung up with wobbles unless someone's flailing their arms or there's a really gross deviation in their trunk position in terms of like a lateral trunk lean. Because with running, you're in motion, you're not statically balancing on one leg. So we use a single leg assessment just to look at her willingness to load and look at which side she initiates on. And sometimes if people do have a little bit of an arm strategy, we can simply take their arms out of the equation. So go ahead back to the starting position, put your hands on your hips, and same thing. So in this case, I'm saying this looks great. Nothing that really jumps out aside from just some very, very light toe gripping, but again, nothing I'm worried about. Let's have you do the same thing on the left side now. Okay, again, no reluctance in terms of loading. It looks like she's working a little bit harder on the left side relative to the right. But again, I don't see any gross deviations that would concern me. One of the things that we like to do a lot is, in Brooklyn's case, we would get her initiating a lot of the single leg drills on her left side because that seems to be her less coordinated side based on our postural scan at this point. Some other things that we can do in this position is we can just do simple heel walking and toe walking. So this is going to give us a window into strength of the ankle dorsiflexors and plantar flexors. So go ahead back to the starting position and just take a few steps on your heels. Great. And go up on your toes. Good. Okay, so we've ruled out any motor deficits in terms of L4-5 and S1-2. Okay, so that looks great. Can we have you go down to touch your toes? You don't need to lock your knees out. Slight bend and just go down to touch your toes. Okay, so just getting a window into her posterior chain extensibility. A lot of times people look at this as hamstring tightness. There's a whole slew of structures that are being put under stretch between the skin, the soft tissue, as well as the neural elements. So in her case, again, no reluctance, and she was able to go down to touch the toes. Now with runners, running is a mid-range activity. This is something that we drive home all the time. So even if she wasn't able to reach her toes, it's still something that's a low level of concern as it relates to her running. Now from an ADL standpoint, it's important because in life we have to do different reaching tasks. So again, we have a window now into posterior chain extensibility. Another simple thing that we can do here is just a simple squat assessment. So what we want you to do is find comfortable, whatever width that is. If you have to toe out, toe in, what we want to do is look at your ability to go as far down as you can into a deep squat. So whenever you're ready, good, and come back up. And can you do that from the side as well? Good, and come back up and do one more time facing us. Okay, so now we're starting to pick up some more meaningful information that's going to dictate above all else perhaps our exercise selection, to also get a window into how we think things are going to pan out whenever she goes to run. All right. So in Brooklyn's case, what we notice is that she's going roughly to parallel, and then she tends to adopt a little bit of a toed out position. So when we see this, we start to basically become a little bit more interested in perhaps her ankle motion or her ankle mobility. So if we want to figure out whether or not that's really what's driving her squat depth or her squat mechanics, all we need to do is place a simple platform. You can use a mat or something to basically take her ankles out of the equation and see if that improves her squat depth. Yeah, bumper plate's perfect. So what we'll have do is Nathan is going to grab some bumper plates and something really just to, these are probably an inch thick. So what we'll do is have her prop her heels on the bumper plate, and we'll have her repeat this and just sort of see what the assessment reveals. Good. And back up and as far down as you can go. Good. Okay. And can you do this from the side as well? So what we notice right off the bat is that she definitely improves her squat depth. So that lends credence to our clinical thought process. Good. And come back up. She has a little bit of rounding. It's nothing we're concerned about because she hasn't reported any complaints in terms of low back pain or any pushback in terms of going into a deep squat. So from here, what we can do is we can take her into a single leg squat, but in the case of runners, let's really just go right into a lateral step down assessment. So Nathan, if you could just grab the platform, which is just around the corner over there. So the lateral step down, as we've mentioned in the past, is a great assessment for runners because it's going to cycle them through the motion that they're going to encounter during the running gait, especially at the level of the ankle and the knee. So we're looking at her ability to progress her leg over her foot, which again is going to be of keen interest to us because it's going to zoom in again or have a system of checks and balances to assess her ankle mobility. And we're also going to cycle her knee through roughly 0 to perhaps 45 degrees of knee flexion. So with the running gait, people are typically going from 20 to 40, maybe 45 degrees. So this is a great window into how we perhaps anticipate things are going to function when she is running. So go ahead and slide all the way over to the edge. Now, if she was sloppy with her single leg balance with the initial screen, we may not even take her here because we're just going to be seeing sloppy mechanics. So whenever you're ready, so just go hands on hips. The non-balancing leg will be straight with the foot level. Lower your body weight down until you kiss the heel on the right and back up. And just do a few repetitions just so you can practice and get acquainted with the assessment. And what you'll appreciate, this starts to basically dovetail on what we saw with her ankle mobility with the squat assessment. So in this case, she doesn't demonstrate any reluctance in terms of loading the left lower extremity, but as she starts to get to greater depths, she goes into a little bit of dynamic knee valgus. There's probably a mild component of femoral internal rotation, and we start to see that contralateral pelvic drop. Okay, so this starts to yield very meaningful information. Let's have you switch up and go to the right side. And we see a relatively similar pattern. So right now, this works for her. She's not reporting any complaints. She's a healthy young woman. But again, this is going to be important, particularly when we start looking at exercise selection, if we're trying to basically just take her through basic training and wellness conditioning, as well as perhaps performance coaching if she's looking to sort of push her game a little bit. And go ahead and take a break. Great. So now that we've taken Brooklyn through a simple postural scan as well as some assessments in standing, we're going to have her sit at the edge of the table and continue our assessment or clinical examination. So we're going to continue to explore the lower quarter screen just because it takes so little time to do, and considering the fact that most physical therapists and clinicians are working in a direct access capacity, we want to make sure that we're not missing any sinister conditions. And it's not like you just rule these out and you're done with them. You need to remain vigilant, and this is not something that I came up with, but as a good clinician, you just have to constantly stay in communication with your patients and your clients and continue to monitor things just so you're not missing anything. So in Brooklyn's case, there's a bunch of stuff that we can look at in a seated position. So we'll just start by looking at her reflexes. So go ahead and relax. So we're going to just look at the Achilles reflex. I'm just going to bring her completely relaxed. Just let your foot fall to the ground. I'm going to just bring her into a little bit of dorsiflexion and then just give a tap. And 1+ response. I'm going to come over here, again, bring her into a little bit of dorsiflexion, and again, 1+. We'll go up to the patellar tendon and just let your leg fall towards the floor. Good. Good. Sometimes if you're unable to elicit a reflex, you can just have people gently pull their fingers apart, clench their teeth, and rotate to one side, unless they have dental problems, and don't do that. But that's a great way to just get folks to relax. People call it a Jurassic maneuver. The other thing we can do is continue to explore myotomes. So if I have Brooklyn just bring her heels together and say there's no place like home, we're in the Midwest, right? Yeah, come on guys, I know it's dry. So basically heels together, feet out, we're looking at ankle eversion, so we're really looking at the S2 myotome. So hold here, don't let me push you in. Hold, hold, hold. Great. I'm going to just have you point down and inward. Now we're going to look at inversion, S1, hold. Great. Same thing on this side, point down, hold. Great. Go ahead and hold on to the front of the table. We're going to look at knee extension. Okay, so L3, 4. So hold here, don't let me bend you. Hold, 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 hold. And same thing on this side. And I'm intentionally allowing her to stabilize, because if we have her cross her arms, we don't know ultimately what we're measuring, and we're trying to isolate in this particular case. Go ahead and hold here, don't let me bend you. Come on, push, 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 push. Great. And we can also look at hamstrings. So think L3, 4, and then L5, S1. So don't let me pull you out. Hold. Good. Hold here, don't let me pull you out. Good. And sometimes people with proximal hamstring complaints or tendinopathies, that may elicit some symptoms, but we're going to also look at that in prone at a few different angles. So moving along, go ahead and again, hold on to the front of the table, no leaning back. Bring your right thigh up to here. Don't let me push you down. Hold, 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 hold. Great. Same thing on this side. Hold, don't let me push you down. Hold, 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 hold. Good. You're actually pretty strong with your hip flexors. That's an area that is routinely weak in folks. So hip flexor strength is important. Niemuth and colleagues have shown that runners who are dealing with injury actually exhibit hip flexor weakness. We don't know if it's a cause or an effect, but at day's end, if they're weak, you want to strengthen them. And we also know in Brooklyn's case that she has good hip flexion. All right, so we're getting a lot of information. The other thing that we can do in this position, just because it takes literally 5 to 10 seconds, is take her through a slump test. And we're really looking at neural sensitivity at this point. So what I'm going to have you do is go ahead and just completely slouch. Just let your back slouch, make your PT professors very unhappy. And go ahead and slowly draw your chin down to your chest. Keep going, and I'm just going to hold you there. Any symptoms at all right now, okay? So maintain that position, and I'm just going to passively hold you here and then extend the left lower extremity. Any issue there? Nope. Okay. And go ahead and actively pull your foot towards you. And how does that feel?
Fine. And
if this is a sensitizing maneuver, at this point we could just have her keep everything in this position and then just extend her head or look straight ahead. Go ahead and lift your head up. And we would want to see how that impacts her symptoms or her subjective reports. Okay? So in this case, she's a young, healthy woman, no complaints. So we'll move on, but that's, again, something that you want to look at. So from here, what we could do is, you could do a Thomas test, but the table's not going to support her, so we'll save that for a different part of the examination. So let's have you go ahead and lie on your back. Let's have you go head up here and feet down there. Can we move this now? So now that Brooklyn is in supine, or lying on her back, we're going to just take her through simple clinical examination or simple orthopedic examination. So there's so much information that we can gather here that's going to be important when we start to put together, if we're working with her in a rehab capacity, that's going to dictate really where we start. And from a performance coaching standpoint, again, it's going to give us a window into perhaps some of her movement choices as well as exercise selection. So we have Brooklyn with her heels fully supported on the table and just arms relaxed, hanging out on her abdominal region. So one of the first things that you want to just make a note of in this position is one lower extremity sort of excessively rotated or rotated to a greater degree relative to the other. And in her case, it's relatively similar, all right? It's not like one is all the way toed out and the other one's neutral. So again, when we see this, we should see a somewhat symmetrical hip rotational range of motion profile, okay? And even if you do have some asymmetries, that's not a big deal. I mean, the US Open is going on right now, so we know a lot of tennis players like Rafael Nadal. We would see him most likely where his left lower extremity is completely falling out to the side. So you have to be careful because that's a sport-specific adaptation in that lower extremity with him hitting an open stance forehand, okay? So what we're going to do first is I'm just going to inspect. Are there any, perhaps abrasions, wounds, has she sustained a bruise? Just simple things that you're going to pick up. It doesn't look like she has any deformities in terms of her toes. We mentioned she has some mild varus in terms of her knees, but that's a thing. That's her architecture. So what I'm going to start with is looking at her left lower extremity. And when you're working with someone from a clinical examination standpoint, they may not be comfortable, so just tell people what you're going to do so there's no surprises. So I want to just start by saying anything that's uncomfortable, just let me know. I'm not going to do anything to catch you off guard. I'm going to just take a look at your knee first to see if there's any swelling, okay? So I'm just going to swipe up. Okay. So this is called the swipe, the milk test. It's used to assess a knee effusion. Lynn Sturgill and the folks out of University of Delaware did a nice study in JOSPT looking at the reliability from an intra and intra-rater standpoint and shows that this has good reliability. It's something we should be using clinically. So again, no knee effusion. I'm going to just see if she has full knee extension, and she's at probably +5 to maybe 10 degrees. Okay, so that looks great. Any problem there? Sometimes if someone has a displaced meniscal tear and they're reluctant to load that extremity in terms of walking or anything beyond that, and someone is guarding there or they're sort of holding onto the table, you have to be careful because that meniscal tear may be displaced and creating a mechanical block in the knee. But you'll pick that up through this assessment, okay? So again, she has good knee extension, no swelling. I'll look at a Lockman test just because I want to make sure, she hasn't reported any ACL issues, but I'm just going to have her gently roll out to the side and just let that relax, okay? And you feel a nice distinct thunk, okay? So when we roll out to the side, we're just putting the ITB on slack a little bit. And that's, again, an important test to look at as a cluster of signs, symptoms in the event someone's reporting ACL pathology. But again, with runners and triathletes, generally low likelihood, unless they had some traumatic incident or formerly played a different sport that involved cutting, such as soccer or basketball. So from here, I am going to passively bring her into a straight leg raise. So I'm just using my forearm to sort of make sure the knee is in full extension, and I'm letting her ankle move free. I'm not doing anything to stabilize, and I'm also controlling for rotation just to keep her neutral. So I'm going to passively bring her up. So she's just shy of a 90-degree straight leg raise. So again, that's consistent with her standing forward flexion. So from there, I would move on. I'm going to just bring her up into hip flexion. Can you let your arms relax at your side? I'm going to just take her into hip flexion and give a little bit of overpressure, monitoring for when her pelvis wants to rock into a posterior pelvic tilt. And how's that feel? Great. And it's pretty clean motion. A little bit stiff at the end, but she's not wanting to deviate out. And that's something we often see with folks who have femoroacetabular impingement. So from here, I'm just going to look at hip rotation. So we'll take her into external rotation, and we'll say maybe about 55, 60 degrees, gentle shake, and then take her into internal rotation. We'll say about 40 degrees. All right. We can also, again, just look at hamstring extensibility, and again, very minimal. All right. From here, we're also going to want to just look at knee flexion. Okay, so I'm going to just take her down, give her a little bit of overpressure. For older individuals, people who have past medical history remarkable for meniscal pathology, they generally don't like end range knee flexion, especially if you're applying a little bit of overpressure. So in her case, her heel's almost to her bottom, no complaints. This is, again, a young, healthy woman with a relatively unremarkable clinical examination thus far. We can get a window into great toe extension. I like looking at this in an open chain as well as a closed chain, especially with runners, because that's how they're going to be loading up the great toe. I think as long as someone has at least 35 degrees, it's something that I'm not overly concerned about. And there are people with less than 35 degrees who are actually running without issues. So again, you have to take people on a case-by-case basis. This is what I call the table test. This is something that there's no clinical research on, but it's something that pulls all this stuff together. So what I'm going to do is just run my fingers along the medial aspect of her foot, and you'll find a valley. And as I'm running along the medial aspect of the first metatarsal, and I hit that valley, the next bone up is a medial cuneiform. So I'm just going to stabilize the proximal aspect of the first metatarsal, letting the rest of the foot be free. So I'm going to have Brooklyn bend up to 90 degrees. And once her foot is flat, I'm going to have you slowly draw your knee out to the side. Keep going, keep going, keep going. Push, 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 push. And that's her end feel right there, okay? So I use this as a simple just screening assessment. And I start to become more interested, and you can come back to neutral, when someone has a marked limitation, meaning really less than 30 degrees. Because anecdotally, the clinical practice pattern that I've seen is when people have a limitation with that abduction external rotation, which is looking at twistability of the foot, it's looking at mechanics down at the distal tib fib in terms of rotation as well as proximal tib fib. I get so much information from it, but it also tells me if that's limited, I expect them to have limited ankle dorsiflexion. And it's a very common pattern. There's always exceptions to the rule. But in Brooklyn's case, I know that she's going to have actually relatively adequate ankle motion. So bringing things back, the question is this a motor control problem with her step down? Is it a weakness somewhere else in the kinetic chain? Because it seems like she's going to have adequate motion to be able to perform a lateral step down. So we're going to look at all the same stuff on the right side. So again, I'm just going to look at whether or not she has any swelling. And I didn't get into this. You can also look at patellar mobility, but generally that's not something that I'm concerned about unless there's a post-surgical situation involving the knee. Go ahead and roll out to the side and really let that relax. Okay, she has a distinct thunk there. So again, we know the ACL is intact. I'm going to make sure she has full knee extension. Okay, and again, probably 5 to 10 degrees. I'm going to just passively bring her up. Okay, and again, a little bit more extensible on this side. There's a little bit less resistance when I get her up into the end range. Does it feel like that way to you? Mm-hmm. Good. So I'm going to just bring her into hip flexion, just let that relax. Okay, and again, clean hip flexion, even a little bit more so relative to the left side. And just bring her into hip ER. Again, probably 55, maybe 60 degrees, and then hip IR. Okay, and she has noticeably more hip IR in this particular situation. Okay. And I'm not going to be drawing attention to this to her. I need to piece everything together up here before I start saying where do we go with this. Bring into knee flexion. Again, no pushback with overpressure. And we're going to look at great toe extension, no issues. And again, so tracing my hands along the medial aspect of the first metatarsal, when you feel the valley, you're going to just drop down. Wrap your hands around. Go ahead and bend up. Good. And slowly draw the knee out to the side. Keep going, keep going, keep going. So, and again, greater than 30 degrees on both sides. Okay? And come back to neutral. One of the things that I didn't discuss, just because in Brooklyn's case, she had failed to report anything in terms of any trauma to her knee, but we can look at varus and valgus stress testing. So slide all the way over to the edge. I know you're in PT school right now, and this was never explained to me in this way, and it's such a simple way of looking at testing the collateral ligaments. So I always want to basically minimize work that I have to do as a therapist. So I'm going to just bring Brooklyn off to the side. I'm going to let her knee bend about 30 degrees and just really let that relax. And I'm just taking her into a varus force to check the LCL. And this is also something you're going to want to do with posterior lateral corner injuries. Okay? And do you feel how that just sort of snaps back? Okay? And we can do the same thing with the MCL. So again, let the knee bend about 30 degrees, neutral rotation. And you'll just feel the collaterals check up and sort of like rubber band back. All right? Go ahead and slide back over to the middle. Another just simple assessment. What's that? Okay. Can you slide all the way over to your right side? Demanding cameraman. So, again, at the edge of the table, I'm going to bring you to about 30 degrees. And just really let that relax. And you'll feel it just sort of snap back. Same thing here. Great. Okay, and come back to the middle. One of the other things that we can do with Brooklyn in this position, if it's too, if the table's too cushioned, I would just do this on the floor or on a more of a firm surface. But let's look at her bridge. All right, so go ahead and bend both knees up, feet flat, and we'll just do a standard bridge at first. So go ahead and just lift your bottom off the table so thighs parallel with the trunk. Great. Okay. And let's have you do the same thing. Go ahead and bridge up. Hold that position, and I want you to straighten one knee. It doesn't matter which one, okay? And just bring this down a little bit. Hold that. I want to look at how well she controls things from a rotational or transverse plane standpoint. So I really am looking to see how well she keeps her pelvis square with the ceiling. This is looking at strength of the spinal extensors. It's looking at strength of the glute max in this position. And the glute medius is also working pretty hard from, again, a transverse plane control standpoint. And go ahead to the other side. And I'm also making a note which side she starts on. Good. So again, in this particular position, it looks great. There's nothing that I'm concerned about, and she has great control. You can also look at single leg bridges. So go ahead and just draw one knee up towards your chest. And you can just, in terms of looking at capacity here, you could just have her hold that one knee to the chest and go ahead and just do bridges until you feel like you fatigue. Now, she perhaps could go all day, but what I like to do is to use a metronome to this sometime and have her just stick with the beat. And when she can no longer do that, I stop the test. Okay, and then obviously we're going to do a side-to-side comparison. All right. One other thing that you can do, and I already assessed hip flexor strength, but we can look at what happens when we apply a little bit of a load at the distal thigh to that bridge with straight leg raise. So go ahead and bridge up again, straighten one leg, lower it a little bit, hold there, and go hands on hips. Just be consistent with your assessments. I'm just going to hold here. Gentle force, slowly increasing it. Same thing on the other side. Good, hold there, don't let me push down. Good. Maybe a little bit more challenging on the left side when her left foot's in contact, but overall relatively unremarkable. All right. So at this point, what we can do is have her go into a side lying position. So go ahead and just roll onto your side. And as the examiner, you always want to stay in front of people, okay? Because otherwise, you sort of create this element of perhaps surprise, or it may increase one's anxiety. So again, be predictable when you're working with people. So in this particular position, I'm going to look at side lying hip abduction strength. So what I'm going to have Brooklyn do is use your right hand, and I want you to hold on to the table here. I want the hips stacked. Can I put my hands here? I don't want people rolled off to the side or rolled forward too far. I want them neutral, hips stacked. And what I'm going to do is I'm going to bring her up passively, and I'm going to extend to really isolate the glute medius, okay? So holding here, keeping the foot parallel, avoid toeing out, lead with your heel slightly. Don't let me push you down. And I'm doing this as a break test. Push, 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 push. And she's actually one of the strongest women I've tested. In working with athletes, I like to use a break test because the performance demands of their sport, really pending the sport, but generally they're going to be much greater, and you need to make sure that you know their strength. So again, you can do a make test, but I would encourage people to do a break test and break them through the range and just see what the weakest point is. In this position, we can also look at an Ober's test. I don't always do this, but what I'm going to have Brooklyn do is bring your left thigh and flex it up. And I want you to actually use your right hand, hook underneath. And I know they didn't teach you this in PT school, and this is why this test is so bastardized. And I want you to hold on to the table. So hook under here and hold on to the table. This way I definitively know that she's anchored in place. Okay? So what I'm going to do is I'm going to just bend her knee a little bit. I'm going to flex her up, abductor, okay, and really get her into full extension, maintaining this 90 degrees of knee flexion, okay? And then I'm just going to let her drop down. Okay, so I look at this as tight, normal, and loose. Tight would be above parallel, normal would be parallel, and loose would be below parallel, all right? So again, that's how I was taught the Obers by Dr. Nicholas Sr., and I think it's a really slick way of doing it, and it's good for basically consistency and reliability's sake. All right? And you're also going to get an appreciation for how tight or the extensibility of the iliopsoas complex. So again, you're processing a lot of stuff here. I would repeat this on the other side as well. All right? So let's have you go ahead and lie on your stomach. So far, so good?
Yep.
Okay. So moving along here, we have Brooklyn in prone. I'll use some fancy words because she's a PT student. I need to impress the the model. So in this position, we're getting a window into, does she tolerate a greater degree of spinal extension? So one of the first things that we can do is we can look at her ability to extend up. So can you go ahead and just prop yourself on your elbows? And does that bother you in terms of spine at all, low back? And how about if you go into a cobra position where you're really propped up? Any issue there? Okay. And this would be important, especially if you're working with, and you can go ahead and relax. This would be important if you're working with soccer players, gymnasts, figure skaters, people who may be at a higher risk for a stress fracture or a spondylolysis. Or even a spondylolisthesis. They may not be great at tolerating this. So again, it takes 5 seconds. We take her through it, assess a response. What I'll do here is I can also just look at rectus length. Okay? So again, bring her up passively. And one of the things that you have to be on the lookout for here is a lot of times people may want to abduct the thigh, because that's going to give them a little bit greater range. So again, be consistent. So I want to make sure that we neutralize her thigh in terms of AB, adduction, and then I'm just going to basically bring her heel towards her bottom. All right. We'll do the same thing on the left side. Good. And again, pretty good extensibility of the anterior thigh. All right. What we can also do is bring her up and look at internal rotation of the hips in this position. So go ahead and draw the knees together and just let the legs completely relax. And we're going to take her out to the side. So again, we see this greater degree of hip internal rotation on the right side, but she has good motion bilaterally. there's some research that talks about people who have low back pain consistent with perhaps sacroiliac complaints that lends credence to this hip IR asymmetry. But again, I'm not jumping to any conclusions right now. I'm just making a note of this and trying to make sense of it based on her subjective complaints or reports. One of the other things that we can do is look at ankle dorsiflexion in this position. So I'm going to just bring her up to 90 and bring her into a dorsiflex position. So when you bend the knee or flex the knee to 20 degrees, you eliminate the restraining effect of the gastroc, which is a two-joint muscle. So I'm going to just bring her up, drop her down, and she has over 20, probably close to about 25 degrees there. All right, we'll do the same thing on the left side, and again, relatively functional. Okay, so over 20, probably close to about 25 degrees. One of the other things that I'll do is, again, just to take her through a screening process, is just to apply some gentle overpressure in the lumbar spine, just to see if it's something that's irritable, if it reproduces any discomfort. And I don't feel any guarding or spasm. And does that bother you at all?
Nope.
Okay. So from this position, we can also look at knee flexion or hamstring strength. So feel free to hold on to the table here. If you have a handheld dynamometer, you can basically use a towel and just apply pressure. So again, go ahead and hold here. Don't let me bend you. I'll start at 90 degrees. Great. Relax. I'll take her down to about 60 degrees. Don't let me push you down. Relax. And take her down to about 20 to 30. Hold here. Don't let me push you down. Good. And you're really seeing if this reproduces anything at the level of the sit bone or where the hamstring originates. And she had good strength there. There was no apparent weakness, and we would repeat this on the other side. So hold here. Don't let me push you down. Good, and relax. And you can also be on the lookout to see if they're losing pelvic position, because that may be a compensatory strategy. And let this relax a little bit. Hold there. Don't let me push you down. You can sometimes provide stabilization here. Relax. And hold there. And don't let me push you. Good. And relax. All right. So you can go ahead and sit up. The only other thing that we didn't look at is hip external rotation strength. I would encourage people to do this in a seated position just for stabilization purposes. I'll show that really quick. So again, this is something we would have done earlier in the clinical examination. So go ahead and hold here. Don't let me push your leg out to the side. Good, relax. And we'd repeat this on both sides. Mary Lloyd Ireland has documented hip external rotation weakness in females with patellofemoral pain. So again, you just want to understand the different risk factors as well as how to be comprehensive and thorough. So the more information that we get from the initial assessment or clinical examination, without necessarily being overly exhaustive, but we want to have a clear-cut idea of what the issues are at play and how to basically get out of the gates in the best possible manner. So hope that gives you some stuff to think about. Again, there's probably some other things that we could get into, but this is sort of the crux of what we're looking at from an assessment or clinical examination standpoint. We didn't get into a lot of the joint play assessment, but again, that's for another topic or time. So hope this helps, and that's it. Thank you, Brooklyn. So what we're going to talk about is the table test. This is something that I accidentally developed about 6 years ago in working on my wife. And since that time, I've developed a much greater understanding and a refined appreciation for how this ties into our clinical reasoning. And what it's really looking at is how the foot impacts things upstream. So I'm going to just walk you through the assessment and discuss some of the handholds and some of the considerations. So what I'm going to start by doing is just using my pointer finger and middle finger to just sort of gently trace along the medial aspect of the foot, along the first metatarsal. and you'll get to a point where you hit a valley. Once you reach that point, what you're going to do is drop your fingers down and stabilize the proximal aspect of the first metatarsal. That way you're not blocking out the medial cuneiform or anything proximal to it. From here, what I'm going to have our model do is go ahead and bend up your right knee until the foot goes flat. All right, and I want to keep the foot in neutral rotation just for the sake of consistency and reliability. And I'm going to have her slowly draw the knee out to the side while I'm stabilizing the foot. So go ahead and you can go a little bit faster. Push, 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 push. And right there is her end feel. Okay, there's no more motion that can be obtained by her pushing out. And I'm having to work relatively hard to just stabilize her foot. And back to neutral. Okay, so again, run your fingers along the medial aspect of the first metatarsal until you feel that valley, and there's a little bit of a drop off. It's readily identifiable in most people. You're going to hook around the proximal aspect of the first metatarsal. I'm using this hand to reinforce my grip. Bend up until the patient's foot is flat, and then have them draw the knee out to the side. Okay. And a normal end feel for this is a sense of tissue stiffness at the level of the foot. Okay, back to neutral. So when we're doing this assessment, what I'm really measuring is the angle. If we say this is 0, and you could use a digital inclinometer or eyeball it, I'm looking at how far out she's going. So if this is 0, I want to see at least 30 degrees of abduction and external rotation. Okay, and if she goes beyond that, that's fine. And we're going to look at this side to side and just see what the difference is. So the reason this is important is because if we see a limitation in this abduction external rotation position, what we tend to see is a loss of ankle dorsiflexion, as measured in a half-kneeling weight-bearing lunge or in prone with the knee flexed 90 degrees, which is the way Robin and colleagues et al. Routinely use it during their research studies. The other clinical practice pattern that we'll see is a lot of the times, and we'll demonstrate this on another model, but we'll tend to see one side that's more externally rotated or toed out. And what we expect to find in that particular case is they'll typically have a little bit less hip flexion, or it won't be as smooth as we take them into hip flexion. So we may see the person get up to a point here and then slowly want to deviate out to the side. We'll also tend to see this person have a greater degree of hip external rotation on the side that's asymmetrically toed out, or the lower extremity that's sort of rolled out. We'll see a relative loss of internal rotation, a loss of terminal knee extension, and as I mentioned, a limitation in ankle dorsiflexion compared to the other side. The greater that difference, or the magnitude of that difference is side to side, the greater the differences in these objective measures we anticipate. And again, there's always exceptions to the rule. There are outliers. Where do I find this particularly helpful? People after lateral ankle sprains. We can see this in folks with patellofemoral pain. I routinely find this pattern in folks with FAI. So again, there's a lot of research that needs to be done from a validation standpoint as well as reliability, but this is something that I've been working with now for 6 years, and it's a very distinct clinical practice pattern that gives us a window into not only how the person will operate from a closed chain with single leg drills, but what objective findings that we should be anticipating upon clinical examination. So again, the table test, something to have a practice with. Be really strict with your handholds, and just being consistent with looking at things day to day or from treatment to treatment, as well as within treatment. So that's it. Thanks for watching.